Good evening. Welcome to my next installment in the GHAPP MASLD MASH Community Network. We've done a few of these, and tonight I will be presenting a single patient case with MASH, formerly known as fatty liver disease or non-alcoholic steatohepatitis. There has been a name change, and we just need to embrace the new MASH and MASLD. So we will review two scenarios and discuss management strategies for patients with F3 and F4 fibrosis. It's sometimes challenging to distinguish between these, but there are key elements to simplify this. So let's get started. The case comparison. So I'm Michelle Barnett. I'm a physician assistant in Colorado Springs. I work with Peak Gastroenterology. My focus right now is primarily hepatology. Please use this QR code if you'd like to register for CME. And if you're interested in additional information, including disease state education and Madrigal for promotional program, please click on this link as well. So I'd like to introduce Sam. Sam is a 55-year-old gentleman who was seen by his primary care doctor for an annual physical with complaints of fatigue. He was found to have elevated liver enzymes, therefore an abdominal ultrasound was done, which showed increased echogenicity. He was then referred to our GI clinic for further evaluation. So if we take a look at his medical history, he has type 2 diabetes, hypertension, hyperlipidemia, sleep apnea, and it's important to note no alcohol use. We'll talk a little bit more about alcohol in just a couple of minutes. On physical exam, he's obese, no stigmata of advanced liver disease, which would be palmar erythema, spider angiomata noted on the neck and chest area, and he did not have hepatosplenomegaly on exam. And his vitals showed a little bit of elevated blood pressure, otherwise pretty stable. His labs did show AST and ALT elevation in a hepatocellular pattern, which means it's just the AST and ALT. His alk phos was normal, total bili was normal, and more importantly, the platelets are normal. And platelets are going to be a key to helping us distinguish between the F3 and F4. His hemoglobin A1C was 7.1, consistent with diabetes. That's not really well controlled. Creatinine's normal, INR is normal, ferritin a little bit elevated at 780. It's not uncommon to see that with patients with fatty liver disease, but his iron saturation was at 30%, which would lead us to not be concerned about iron overload. His ANA is positive at 180. That by itself is not diagnostic. It's one of the markers for autoimmune disorders, and it could be a variety of things. It's just good to note that that's normal as we move forward. The rest of the testing, a SMA, hepatitis C, hepatitis B, surface antigen, and antibody are all negative. So once we've identified a patient that is at risk, we do a fibrosis assessment. We really need to know how to stratify these patients. The simplest thing to do is a FIB4. This can be done through an app on MedCalc. It can be done on Epic with a dot phrase, .fib4. And it really helps to stratify low risk, intermediate, or high risk. In our patient, we've stratified him with a FIB4 of 3.1, which puts him in an intermediate category. Since I work in a GI office, I have the ability to do the FibroScan. The FibroScan on this gentleman then shows us that he has significant fibrosis in an F3 category, and his CAP score, which is the steatosis score, shows moderate steatosis. If we didn't have those available to us, or there was a discordance with the data, we could do an ELF blood test. And locally, this is done through Quest and LabCorp. And it's another test that's very reliable on predicting somebody with more advanced liver disease. So at this point, we look and say, is there anything further that we would want to do, any additional testing that we would like on this patient? So I'd like a little bit of clarification. With patients with multiple comorbidities for MASLD, I would recommend ordering an abdominal ultrasound complete, not just a right upper quadrant ultrasound. In this case, we don't know what was ordered, but it would be helpful to always be able to look for portal hypertensive changes, splenomegaly, and that will again help us distinguish between the F3s and F4s. I would also want a PEP. A PEP is a 30-day average alcohol use. It's kind of like a hemoglobin A1C, but for alcohol. So it's not testing an alcohol level, it's what that average has been over a period of time. It's really important to clarify alcohol use. By definition, MASH is primarily metabolic. with no significant alcohol use. And if a patient has 2 to 5 drinks a week for women, 3 to 8 drinks per week for men, and risk factors, that would be a different category, something called MET ALD. If they drink this much daily, they might have alcohol use disorder or definitely alcohol-related liver disease. And that's a different talk on a different day. So keep in mind, one drink is 12 ounces of beer, 5 ounces of wine, or 1.5 ounces of a spirit. The other thing I would do is clarify his vaccination status, because if you've got somebody who's got advanced liver disease, we need to determine whether we need to vaccinate that person. So an HAV total would be done, and I would do, to complete this workup, the hepatitis B core antibody total to see if he ever had exposure to hepatitis B. Now, how would we stage this patient? It's pretty clear he's got F3, advanced fibrosis, no red flags for cirrhosis, normal platelet count, no mention of splenomegaly, no physical signs of advanced liver disease. So let's discuss patient care. How would you treat this patient? It's not a simple question anymore. He has multiple comorbidities. MASH is a cardiometabolic condition and needs a multidisciplinary approach. He has hyperlipidemia. He's on a statin. He has diabetes. He may have an endocrinologist. We need to find out who the players are so that we know and we can work together with any other specialist who may be wanting to start this patient on certain medications. So let's discuss these issues. So resmetirom is now the first medication approved for MASH in patients with F2 and 3 fibrosis. This must be prescribed in conjunction with lifestyle modifications. Patient needs dietary changes, portion control, calorie-restricted diet, and guidance to achieve this. So many have often been told they just need to eat less carbs and sugars, but we need to have the right carbs and a balanced plant-based diet. Mediterranean diet is key. I provide links to my patients, a dietitian consult, tell them that I will help them, show them how to do this instead of just telling them what they need to do. They need a formal exercise program, an accountability partner, exercise logs, perhaps an Apple Watch to count steps, apps to track their exercise. Some may be severely deconditioned and they have to start with chair yoga or wall Pilates, upper body weights while they're watching TV or while they're watching commercials. We cannot just recommend Orange Theory or CrossFit training if they currently go from the couch to the kitchen. So we really need to figure out what their level of exercise is. If we emphasize steatosis is reversible, and we can then challenge the patients to look for modifiable factors, things that are modifiable, what you do activity-wise, what you put into your body, and what you drink or not drink. Recent studies support both cardio and resistance training to achieve our initial goal of 7 to 10% total body weight loss. And that's what's needed to initially reverse steatosis. They may need to consider GLP-1 medications. They are not currently approved for MASH. However, several of these medications are approved for both diabetes, obesity, and cardiovascular risk factors, and this patient does fit into that category. So in my practice, I would send a message back to the primary care stating patient had severe, moderate to severe steatosis. We are looking at everything we could do to try to aggressively reverse this to prevent progression. One key point also for monitoring HCC, any patient with F3 or F4 is at increased risk for cirrhosis. They must have an abdominal ultrasound and an alpha-fetoprotein every 6 months for life. So that's key as we go forward too. So with Sam, our patient, we start him on resmetirom. We monitor labs every 3 months, repeat a FibroScan in 1 year, along with an alpha-fetoprotein and an abdominal ultrasound. Now, if that abdominal ultrasound shows any abnormalities at all, there's usually messages that state, that additional testing might be needed, an ultrasound or a CT scan or an MRI. I like to put in my notes when I order it that if there is anything like that that's highly suspicious, to put in their report that they recommend additional imaging, just so that I don't have as many problems getting that approved with insurance companies. So now imagine the same patient, but with a little bit different profile. Case 6B has different lab values. Same gentleman, this is Sam, 55. But when we get to the labs, we see that his total bili is a little bit elevated, 1.4. His platelets are low at 128. His creatinine is a little bit high at 1.3. Now, this is a patient with both diabetes and underlying hypertension, so this might be a bit of renal insufficiency. But it's good to note because this will change how we stratify this patient. So as we calculate what his fibrosis scale is, we will see that his FIB4 is calculated at 3.36, which puts him at high risk. FibroScan is done. He clearly has advanced fibrosis or cirrhosis. We typically use a cutoff of 12.5 kilopascals as our determination for cirrhosis, and he's over that at 21. Now, interestingly, his CAP score with the fat in the liver is decreased, and it's not uncommon for patients who have more advanced scarring to lose the ability to hold fat in the liver. So this is what we call burned out NASH. And so it's not uncommon. I get a lot of people with F4 on their FibroScan and S0, and that's typically the picture we see. ELF blood test is something that, again, is done if there's a discordance, if we have high suspicion for one or the other. And in this day and age, a NIT or a non-invasive test, typically several of them need to be used to get a real clear picture of what's going on with the patient. These are all still non-invasive, and used together, they can help us stratify these patients. So again, we've done this. Now, what else would we want to do additional testing on him? So a patient who's 55 who has cirrhosis needs to have additional testing looking for ceruloplasmin, alpha-1 antitrypsin, the autoimmune markers, including an AMA in his case, and a PEth. I do a PEth on just about everybody. Oftentimes, people that drink wine every night at dinner don't think that that's using alcohol in excess. And sometimes it depends on how big their wine glass is, but you need to either kind of look at this as a MET ALD picture or look at this as a MASH without the alcohol component. This patient would need an upper abdominal ultrasound to screen for HCC and also to assess for portal hypertension. And we'll need an EGD to screen for varices. How would I stage this patient? This is MASH with cirrhosis, FIB4 stratified to high risk, supported by findings on abdominal ultrasound, of course, if we had the splenomegaly noted on there, low platelets, FibroScan with S0F4. And again, the ultrasound findings might show hepatomegaly if someone has fatty liver changes, and it might show a small nodular contour to the liver if it's truly cirrhosis. So let's consider treatment options for this patient. What we typically need to do is remember that the resmetirom is used for patients with F2 and F3 fibrosis, but it would be contraindicated currently in a patient with advanced liver disease. So we need to focus on the diet and lifestyle. That would be no alcohol, a high protein diet to help decrease muscle wasting or sarcopenia, which we can often see as cirrhosis progresses. Low sodium diet, really with a focus on 2,000 milligrams per day or less. The key point here also is it's okay to use Tylenol or acetaminophen up to 3,000 milligrams per day if needed. They should check any cough or cold medicines to make sure that they're not receiving acetaminophen from multiple sources. All patients with cirrhosis should avoid nonsteroidals because of the risk for bleeding. And in his case also because he had an elevated creatinine. Baseline EEGD is needed to screen for varices. If a patient has varices, they may need treatment with a non-selective beta blocker such as carvedilol. This can also help control portal hypertension. So as we compare the patients A and B, the key takeaways are really looking at a few lab values and NITs that we can then stratify. FIB4 was normal or actually in a moderate range for the first case, definitely into a cirrhosis case for the second. Platelets, again, being low, always think liver. I see a lot of people who are referred to hematology, and then they're sent from hematology back to us for a more thorough liver evaluation. I like to always say start with liver, and then we can always move somebody into hematology if we need to. Elastography is going to be key on these patients. It needs to be done properly. That means that patients need to come in fasting for this. They need to have no food for 12 hours. I like to 12-hour fast with this. And I like to have avoidance of alcohol for 30 days if possible. Sometimes that's not possible. And if the ultrasound is done with the entire abdomen, not just the right upper quadrant, we can assess for splenomegaly. We still do liver biopsies. In some cases, this is gold standard to clarify the cause of liver disease, but non-invasive testing is reliable. So to summarize, you are now able to identify risk factors for MASH. You can risk stratify patients with a FIB4, refer if intermediate or high risk, look for low platelet count, consider complete abdominal ultrasound, not right upper quadrant, ask about alcohol use, diet and exercise, and provide resources to formulate a successful management plan for life. We've kind of looked at how these patients compare and contrast. And again, surveillance is important. In hepatitis C, we learned that patients who had significant fibrosis and even cirrhosis who were treated with hepatitis C and had regression of their disease were still at high risk for cirrhosis, even if they regressed back to stage F2. And there was a HALT-C trial that was done at the University of Colorado and several other places that really did prove that the risk for liver cancer remained high with these patients. So even though they might have at one time been an F4 and now they may have had regression, we need to continue to screen them because that risk does not go away. So thank you for your time today. I hope that this has provided key information on distinguishing between F3 and F4. And I hope that you will join me in the future for another discussion on our MASH community network.